Our final speaker today is Avik Roy, who's president of the Foundation for Research on Equal Opportunity, which is a nonpartisan, nonprofit think tank that conducts original research on expanding opportunity to those who least have it. He's also the opinion editor at Forbes and the author of Transcending Obamacare, a patient-centered plan for near universal coverage. He also serves on the advisory board of NIHCM Foundation, and we're so pleased he's with us today to share his perspective. Avik?
Thanks, Catherine. Before I start, I should mention that one of my colleagues on the advisory board, Uwe Reinhardt from Princeton, has passed away last night. So I and everyone else, I'm sure, want to pass on my thoughts to his family and say how much he'll be missed by myself and I think many other people on this call. What I wanted to talk about today in a complementary way to what we've heard about from everybody else is to kind of go back a little bit historically. I think we understandably focus always in the policy world on what's right in front of us, what's upcoming. And when it comes to the stabilization of the individual market, we have a conversation about CSRs. We have a conversation with things that are that are hot today, and we tend to neglect the fact that the instability that we've had in the individual market didn't start in 2017. It started in the fall of 2013 when we started enrolling people for the 2014 plan year, because that was the first year that the ACA'S regulations went into place. So I want to kind of discuss in a more broad way, or a more holistic way, the various ways in which the individual market has been destabilized and what we can do to try to improve that stabilization so that we're achieving the twin goals of making health insurance, or shall we say the triple goals of making health insurance affordable in the individual market for people who are sick, people who are poor, and people who are neither of those things, but also need coverage. So one element of how the individual markets evolved over the last 4 years is that enrollment in the ACA exchanges has been significantly short of what the Congressional Budget Office projected in 2010. So what this chart is showing you is the various projections from the CBO. The most recent one isn't in this slide, but the most recent one that revises even further downward from 2016 has enrollment in the exchanges peaking at about 12 to 13 million. But in reality, we've seen much lower enrollment than what the CBO projected. There are some who argue that this is because there's been unusually high employer-based coverage. My view and the view of others is that's not actually what we've seen. If you actually look at where the differences between the CBO's original projections and the results and the reality, the real-world effects today, the vast majority of the difference isn't coming from unusually high employer-based coverage numbers, but rather simply because the individual market has gotten so expensive that a lot of the people who CBO expected to enroll haven't enrolled. And so why is that? Well, first of all, of course, I'm not telling you anything you don't know to say that premiums have increased in the marketplace. I think one thing that I'm trying to illustrate in this slide is that they've increased across age groups. So despite the fact that you have the 3-to-1 age bands, which in theory should mean that all things being equal, people who are in their, say, 60s, early 60s have an advantage relative to the old system, that hasn't actually been the case because of a lot of the adverse selection and other elements of the benefit changes that the ACA imposed. So if we look at what actually drives those changes, I think one thing you hear, and I'm sorry these numbers are a little small on this slide, and we'll try to make them available later so you can take a look at them more closely. But here's an example of a plan from Kaiser in Sacramento, California, and I think the thing I'm trying to point out here is that what you'll hear people say is, well, the reason why the plans are so much more expensive in the post-ACA environment is because the coverage is better. The coverage is more financially generous. It covers more things, et cetera. So what I'm showing you here is two plans that are nearly identical, one from 2013, one from 2014, issued by Kaiser. And what you'll see here is if you can make out the numbers, the provider network is actually the same. So unlike a lot of plans where the networks got narrower in response to the ACA, here you have a plan because of the integration in Kaiser. You have a plan where the provider network is identical in the 2013 and 2014 markets. The actuarial value is almost exactly the same. It was 60.5% for the 2013 plan and 60.4% for the 2014 plan. And the deductibles and benefits were pretty much the same with the important exception of prescription drug coverage, where there were some differences that probably amount to, let's call it, a 5 to 10% difference in premium value for an individual who's signing up for that plan. But as you can see, the premium in the 2014 plan is more than double what the 2013 plan was, despite the fact that in terms of the otherwise what the structure of this plan is, it's basically the same as the plan in 2013. The point being that there are a lot of ways in which the ACA changed the insurance market that for a lot of people didn't meaningfully change the quality or financial generosity of the coverage that they purchased. It simply made it more expensive. I'm going to go to another slide here, which is another way of thinking about this, and this comes from a study that Milliman did, and this looks at the state of Wisconsin. So why Wisconsin? Wisconsin is a state that you can say had kind of the typical regulatory structure of a pre-ACA state. So as you all know, or as many of you know, there are a handful of states in the pre-ACA world that had guaranteed issue, that had age bans, things like that, the New York, the Massachusetts, et cetera, but the majority of states did not, and Wisconsin is one of those states where there was a real difference between the pre-ACA and post-ACA environment. What this slide is showing you is Milliman's analysis of what the drivers were, estimates of what the drivers were of premium increases in the 2014 versus 2013 environment for a 27-year-old healthy male and a 57-year-old unhealthy female, so you can get some visibility into how the ACA affects different actuarial populations. And the point of this slide is to show you that there's a perception out there that the real drivers of the higher premiums in the ACA were guaranteed issue and community rating by health status, and that's kind of something that's come out of a lot of the media coverage and political commentary, in which because guaranteed issue and age and health status-based community rating were politically popular, those were things that were emphasized as features of the ACA. But if you actually look at what's happened actuarially, the impact of those provisions, it's there, but it's not as significant as, in particular, the 3-to-1 age rating. 3-to-1 age rating, and to a lesser degree, 1-to-1 gender rating, but particularly 3-to-1 age rating, was a significant driver of premium increases for the younger half of the eligible population. It's important to remember that prior to the ACA, a majority of those who were uninsured were under the age of 40. The vast majority of people who are uninsured in general are younger and simply have lower incomes, because younger people tend to have lower incomes than older people because they're earlier in their careers and have lower earning jobs. And so when the ACA introduced 3-to-1 age bands, it made insurance a lot less affordable for a lot of people in the younger age brackets, and that's been a big driver of adverse selection. There's a degree to which the actuarial value mandates, in particular, and to a lesser degree, EHB mandates played a role. EHB mandates, gets talked about again a lot, but the impact actuarially is not that large, particularly because most of the plans at the state level had a lot of EHB mandates to begin with. So where the federal mandates differed from the state mandates is relatively incremental. But actuarial value was a big driver of higher costs in the post-ACA market versus the pre-ACA market. So the median actuarial value in the pre-ACA market nationally was about 40 to 45%. And obviously in the ACA, with the way that subsidies are keyed to the silver plan, for most people that became 70%. And so all things being equal, when you go from a 40% AV to a 70% AV, you're obviously dealing with a pretty significant increase in premiums. So yes, there is some impact from health status rating and a few other factors, but really a much more manageable impact. So all this to say that if the ACA's regulatory reforms merely consisted of having one-to-one health status rating, say one-to-one gender rating, and guaranteed issue, the impact on premiums and the impact on the stability of the market and adverse selection would have been much more modest than it actually was. The two biggest drivers of instability and adverse selection were the 3-to-1 age rating and the significant shift in the median actuarial value of the plans that were being issued on the ACA exchanges. And what we see as a result of that is pretty straightforward. So this next chart comes from data that Avik Health put together, and what you're seeing here, and the dark bars are the 2015 plan year, the lighter bars are the 2016 plan year. What you're seeing here, and this is based on ASPE data, HHS data, the percentage of people who are eligible, subsidy eligible in a given income bracket, how many of those people have signed up for coverage on the exchanges. And what you see is for people who are at near the poverty line, for whom their premiums are almost entirely covered by the premium tax credits, they're enrolling. The vast majority of those individuals are enrolling. But as you have that sliding scale where the subsidies decrease as you go up the income scale, there's a much, much less enrollment. And what that's telling you is that the impact of all these regulatory changes and the degree to which it increases premiums is having a huge effect, particularly as you get above 200 to 250% of the federal poverty level, and particularly over 250, because as many of you know, over 250 of FPL, you're not eligible for the cost-sharing subsidies, which is another thing that makes the exchange-based coverage attractive for people below that threshold. And so this is a big problem. If the goal of the ACA and the goal of health reformers in general is to make sure that everybody can afford health insurance, we're doing a reasonably good job of making sure that people around the poverty line can afford health insurance. We're doing a reasonable job of heavily subsidizing coverage for people who are really sick, who have really, really high medical costs, because we have guaranteed issue and tax credits. But for pretty much everybody else, we're seeing higher premiums. And of course, obviously, once you get above 400 FPL, as was illustrated earlier, we have a big spike in the out-of-pocket costs that those individuals are exposed to. So let me again step back a little bit more and talk about this conceptually. So back in the run-up to the passage of the ACA, we had a number of people talk about the three-legged stool, right? The idea that you had to have the balance of the regulations, the subsidies, and the individual mandate. All three of those had to be included in the ACA in order for the individual market to work. Why is that? Because the market reforms would drive up premiums. The subsidies would defray the cost of those premiums for some people, and the individual mandate would force the younger and healthier people whose premiums are doubling or tripling back into the market when they face those higher premiums, and otherwise a disincentive to enroll. So that's in theory how the ACA was supposed to work, but in that run-up to the passage of the ACA, there was not enough discussion of the engineering problem of, okay, it's a great metaphor, the three-legged stool, but in order for you to be able to sit on a three-legged stool, the different legs of the stool have to all be the same length, and they have to have the same angle to the ground. Imagine if you had a three-legged stool in which all three legs of the stool were of different lengths. That would be a hard stool to sit on. And that's basically what's happened with the ACA, is that the three legs of the ACA stool are of different lengths, which has made the stool unstable. So the way I would torture the metaphor of the three-legged stool is to observe that the adverse selection that we've seen due to the regulatory change of the ACA are very, very significant. So that's the longest leg of the stool, you could say. Whereas the subsidies are sort of are kind of in the middle. The subsidies do a partial job of defraying the impact of the adverse selection for, again, particularly those people near the poverty line who get the full benefit of the subsidies. but they don't completely defray the cost, particularly for those whose incomes are in that upper range of the 100 to 400 FPL bracket. And then the third stool, the shortest stool, is the individual mandate, which is very weak. It has a lot of loopholes and exemptions. There are large swaths of the individual market participating populations that are exempt from the mandate for one reason or another. And so the impact of the individual mandate is far less than is commonly believed. Between the actual design of the individual mandate, it was watered down and weakened a lot in order to satisfy political concerns, and it also has not been enforced aggressively by the Obama administration or by the Trump administration. Actually, the Trump administration has enforced it a little bit stronger to date, though there's been some discussion of changing that. The individual mandate is the weakest leg of the three. So basically, this is, to kind of go back to the three-legged, so this is the basic problem, that if you want to solve the stability of the individual market, regardless of what happens with cost-sharing subsidies and the stuff that's in the news today and the stuff that everyone's talking about today, if you really want to get stability in the market, this rebalancing of the stool is what you've got to try to address. So how would you do that? Well, there are different ways to balance the stool. You could lengthen the legs of the stools that are shorter, the subsidy and mandate legs, or you could shorten the leg of the stool, piece of the leg of the stool that's longer, which is the adverse selection regulation leg. And that maps pretty reasonably to where the kind of political debate is about health reform. So if you look at the menu that would be shorting the adverse selection leg or shorting the regulatory leg, the two biggest targets, as I alluded to earlier, would be to repeal age-based community rating and to reform the actuarial value requirements to give enrollees alternatives to the high actuarial value plans they currently have on the exchanges. So one key element to this particular slide that's really important to understand is how they interact with the means-tested tax credits in the ACA. So as nearly all of you understand, the tax credits in the ACA are key to your income. Depending on exactly where you are in the income bracket, you have a certain amount of your percentage of your income which you're expected to pay to pay for the premium, and anything above that is covered by the tax credit. And the reason why that concept is really elegant and really important, and particularly why it's really elegant and really important, is it actually makes a lot of the regulations in the ACA redundant. So imagine if you're somebody, if you repeal 3-to-1 age bands and you have somebody who we went back to 6-to-1 age bands, say, de facto in the marketplace. And so in theory, all things being equal, again, you would expect that means that maybe someone who's 62 years old would pay a higher premium. But actually, if they're below 400 FPL, they wouldn't pay a higher premium because that increased cost would be absorbed by increases in the amount of premium assistance they would receive under the ACA. Not only that, you'd have the fact that because you'd have a lot less adverse selection because younger people would be more incentivized to enroll, you'd have a situation where actually overall average premiums could go down because you'd have a better risk pool, right? So the key thing to understand when it comes to regulatory reform is the way it interacts with the elasticity of the premium assistance such that you can actually do a lot to lighten up on the regulations and have the direct subsidies in the tax credit piece do more of the work of defraying the cost of coverage for actuarially high-risk individuals. So this gets to the point in this slide, right? So the key thing, in my view, is to preserve the means-tested structure of the ACA tax credit. As we went through the last 12 months on the Republican side of what Republicans wanted to do to replace the ACA, there was first of all, there was a big debate about whether refundable tax credits were a worthy vehicle at all, and then there was the debate between the House and the Senate as to whether or not tax credits should be flat, irrespective of income, or whether they should have a structure that kind of echoes the ACA's means-tested structure. And the Senate settled on the means-tested structure, which I think is an important area of bipartisan agreement now, that means-tested tax credits are the right vehicle for ensuring that uninsured individuals can afford coverage. Because, again, it gives you a lot more flexibility on the regulatory piece to make sure that you're doing what you can to get younger and healthier people in the pool. One thing that the Senate Republican bill did that was very interesting that alludes to something that was said earlier is it harmonizes the relationship between age and income in the tax credits themselves. So under the ACA, the tax credits purely adjust based on your income, but in the way the BCRA did it is it has a combination, a hybrid model where you'd get more premium assistance not only if you were of lower means income-wise, but also if you were younger. So in order to kind of compensate for the fact that the regulatory structure in the ACA is geared towards favoring older and sicker individuals and disfavoring younger and healthier individuals, the subsidy structure in the BCRA was designed to compensate for that by providing a little bit more assistance with lower income thresholds before the tax credits kick in for younger individuals as a way of getting younger people enrolled in the pool. Another idea kind of bringing us to the current day in terms of the cost-sharing subsidies ideas. Of course, there are lots of ways to simply kind of appropriate the money for the cost-sharing subsidies and continue with our regularly scheduled programming. In my mind, there's an opportunity to convert the cost-sharing subsidies into HSA deposits that enrollees would control as a way of defraying their deductibles and copays. There's some technical things that in this short period I don't have the time to go into in terms of how you would design that, but that might be a way of providing a bit more of consumer engagement in the way that lower-income people who are currently eligible for the cost-sharing subsidy benefit are able to utilize those dollars and roll them over time. So what's the right approach in terms of dealing with the individual mandate? We've heard arguments today from Chris and others that the individual mandate's important to preserve, that there aren't really any adequate replacements for the individual mandate. And I think that would be a stronger argument if the individual mandate were robust in its design and its implementation and its enforcement. But there isn't a lot of evidence that the individual mandate is having a significant effect on market behavior up to this point. And there's been a fair amount of research now on this, which concludes that the individual mandate is not really driving enrollment in the exchanges or in other parts of the market where the Congressional Budget Office believed the individual mandate would be having a significant effect. And obviously, from an ideological standpoint, there are a lot of people who are concerned on the right that the individual mandate is, whether you think of it as a constitutional injury or just a bit intrusive from a standpoint of the government's role in the individual market. Those arguments, to whatever degree you believe in them or not, they are certainly still strongly held in conservative circles. So the question, I think, is there a viable alternative to the individual mandate that would achieve the same goals of making sure that you don't encourage adverse selection, you have perhaps, you limit the ability of people to jump in and out of the market, but you actually do the things you need to do to have a stable risk pool. And there are ways to do that. And so in this slide, I've listed a number of different bullets of what you could actually do without an individual mandate, because, again, the individual mandate in the ACA, it has to be emphasized, is so riddled with loopholes and exceptions and exemptions and is so weakly enforced by the IRS that it effectively doesn't exist. And so there actually could be an improvement on the status quo in terms of encouraging people not to game the system and getting involved in the marketplace. If we did things to limit our ability to game the system like we do in Medicare, we don't have an individual mandate to enroll in Part D or Part C, and yet we have a lot of mechanisms that we use in Part C and Part D to prevent people from jumping in and out of the system. All we have to do, really, to oversimplify, is borrow from what we do in Medicare C and D to have a better system, a more stable system than what we're doing right now in the real world with the ACA individual mandate. A number of people have talked about auto-enrollment as an alternative to the individual mandate. My personal view is that I'm not persuaded that we've surpassed the technical considerations to make auto-enrollment a thing, especially if you maintain a means-tested tax credit in which the tax credit is the amount of financial assistance and the net premium to an individual is varying a lot. How do you actually auto-enroll someone in a plan unless you know exactly what the impact to them in terms of what premium they're going to be expected to pay? If someone really smart has figured that out, I know there are people out there who write about this. I'm certainly open to the idea, but I haven't been persuaded that those technical challenges have yet been met. Let me see if I got the right slide here. Oh, yeah. Okay, great. So what I'm describing, I think one thing I want to emphasize is that the goal of a regulatory structure of the kind that I've just described is to actually try to get more people into the market, to get to that original CBO projection where we have 25 million people enrolled in the exchanges as opposed to 10 million. If paired with a bunch of other reforms that we talk about in our main health reform white paper, Transcending Obamacare, using CBO-style microsimulation analysis, we find that this combination of reforms could lead to 12 million more people having health insurance on net than do today, because the premiums would be lower and the benefit package would be more attractive to a broader range of people, while still, again, ensuring that people with high health costs, whether it's because of health status or their age, would still have the financial assistance they need to afford coverage. For those who are interested in learning more about these ideas or reading about them in more detail, I encourage you to go to the website of our think tank, FREOPP.org, FREOPP.org, where you can download Transcending Obamacare. And I'm happy also to take any questions either now or later. My email address is aroy@freopp.org. Again, that's FREOPP.org. Thank you very much.